everyone, welcome to today's webinar, Surgical Approaches to Cervical Cancer, an overview of treatment options. I'm Aisha McLean, the Cervical Cancer Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We are a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars and support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the panelists finish presenting, we'll begin the Q&A. Please submit any questions through the Q&A section at the bottom of your screen. Remember that our speaker cannot give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of your screen and selecting the subtitle option. This webinar is being recorded. We will share the recording with all the registrants in a few weeks, and it will also be added to our website. I'd like to hand it over to today's speaker to introduce herself. Dr. McLean, the floor is yours.
Thank you. I'm Karen McLean. I'm a gynecologic oncologist at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I both perform surgery and administer chemotherapy to patients with all kinds of gynecologic cancers, and I really love making connections with patients and learning about them beyond just their cancer diagnosis. I also run a basic research laboratory focusing on improving our understanding of gynecologic cancers. I'm involved in education, and when I'm not working, I enjoy hiking and playing tennis. Excited to share with you some new updates we have about cervical cancer management, specifically in the surgical realm. And I'm going to talk about three main areas. First, the diagnosis and workup of cervical cancer as it pertains to subsequent management. Second, some basics about gynecologic cancer surgery and specifically the nomenclature of different surgeries that are performed. And then finally, and most of our time today will be spent talking about recent clinical trials for the surgical management of early stage cervical cancer. And there are really two components here. One is this question of simple versus radical hysterectomy, and the second, laparoscopic versus open surgical approach. And as we proceed today, I'll discuss what all of these terms mean. So most often, a woman is initially considered to possibly have a cervical cancer either because they have an abnormal Pap test or some new symptoms. These are symptoms such as irregular bleeding, pain after intercourse, or bleeding after intercourse. An initial workup includes both a general physical exam as well as a detailed female exam. And this will be bimanual exam, including a rectovaginal exam, which means feeling in the vagina and the rectum to assess the tissues surrounding the cervix, as well as what's called colposcopy. This is a special microscope that's used to look at the cervix during a speculum exam, and generally biopsies are taken during this colposcopy. After this initial workup, the next step is what we call an excisional procedure. There are really two main types that are done. One is called a LEEP, or a loop electrosurgical excision procedure, shown on the left here, and this is a hot wire that cuts out that middle portion of the cervix and up into the cervical canal. And the second is a procedure called a cervical cold knife cone, or conization, or cervical conization. And this is a procedure done in the operating room where a portion of the cervix is also excised. Both of these methods give us important information about what's changing in the cervix and what's the underlying abnormality, and give us initial information with regard to that cervical cancer. So when we get that pathology report back from an excision procedure, there are two main histologic subtypes of cervical cancer that we see. The first is what's called squamous cell carcinoma, which is shown on the left here. And the second is adenocarcinoma, shown in the middle, which is less common. Both are most commonly HPV associated, and these are the vast majority of cervical cancers. However, there are a number of less common cervical cancers, as listed here on the right, as well as other types. And I want to just emphasize today that the management that we're talking about today really pertains to these two most common types, squamous cell carcinoma and adenocarcinoma. And the less common types of cervical cancer can have different management approaches. So one big change is that in 2018, there's an updated staging system for cervical cancer. When we think about staging in general for not only cervical, but all of our cancers, we can think of it like a bullseye, where stage 1 is focused on the disease, the site of origin. So for stage 1 cervical cancer, it's only in the cervix. And then stage 2, 3, and 4 are extending out from that cervix, either local growth or spread to faraway places. One of the other big changes in the 2018 staging system was the incorporation of advanced imaging technologies, including MRI and PET scan, to help define the stage of the disease. So if we look first in the middle picture here, this is an MRI. This white area kind of in the middle left is the bladder full of urine. And then right in the middle of the screen here is the uterus. This black area is normal uterus. The cervix is at the bottom here. And this area right between those X's, that is the cervical cancer. And so MRI gives us a very clear image of the size and the spread of the cervical cancer. Normally, this tissue should be black like the uterus, so it helps us give us great information about what's happening specifically in the cervix from the cancer. On the right is what a PET scan looks like. This is a labeled sugar that goes to areas of high sugar uptake, so it's normal that the brain would show up as a black spot of a lot of uptake. And that dye is concentrated in the kidneys shown in the middle and the bladder at the bottom. So these are not all cancer spots, but normal spots that get signaled during a PET scan. What we're looking for is these other areas. They're shown on the top in yellow, which are areas that are concerning for lymph node spread on the PET scan. So all of this information gives us an accurate assessment of what an initial stage is for a patient's cervical cancer. This then allows us to define what our overall management approach is going to be. I think of this as being 3 categories. First, disease that's confined to the cervix, so stage 1 disease only in the cervix, which undergoes surgery. Second category is what we call locally advanced disease that has spread in the pelvis, also in the pelvic lymph nodes, that we can still treat with radiation. And so these patients get radiation as the primary therapy with a low dose of chemotherapy that helps the radiation work better. It's important to note that in these patients, if you're getting radiation, you generally do not get surgery as well, but just radiation, and that can be with curative intent. And then finally, on the far right, if the patient has distant metastasis, then we need cancer therapy that goes throughout the body. And this is generally chemotherapy with immunotherapy to treat those faraway metastases. So our focus today is really on the surgery approach to stage 1 cervical cancer. Traditionally, for all but the earliest of cervical cancers, patients would undergo what's called a radical hysterectomy. We'll talk about that in more detail in a minute. And our goal is to try and determine what is the best approach for these stage 1 cervical cancers. So I'd really like to spend a minute talking about the words that we use to describe a surgery for a hysterectomy, because I think there can be a lot of confusion, and it's important to know exactly what we're talking about. So first, the word hysterectomy means specifically the removal of the uterus. If it's not specified, then often that includes the cervix as well, but a more accurate word would be to call that a total hysterectomy or a simple hysterectomy, which is the uterus and the cervix. And then next we have what's called a subtotal or supracervical hysterectomy. In this case, the cervix is not removed. So if we look at the pictures on the right, the first inner pink line dotted here is what's called a subtotal or supracervical hysterectomy, meaning just the uterus is removed, but not the cervix. The second type is shown in the orange, and that's the most common hysterectomy that's performed for reasons other than cervical cancer. And that is called a total hysterectomy or a simple hysterectomy. The orange dots come down right next to the side of the uterus, right next to the cervix, and just below the cervix, the orange dots there. And then a radical hysterectomy, and I like that word because it really, it's a bigger surgery. It's not only taking the uterus and cervix, but also 2 additional areas. What's called the perimetrium, which is the area sitting to the side of the uterus and cervix, as well as the upper vagina. And this is what makes a radical hysterectomy, so these red dots here. The way I think about it is we can see the cancer on MRI or on your physical exam, but we're trying to catch any teeny tiny cancer cells that have already snuck out past the cervix. And so we take an extra area of tissue beyond the cervix itself in hopes of catching those small cells that have snuck out. Other point I want to make about the surgical naming is that all these words about hysterectomy do not say anything about the ovaries and fallopian tubes. So if your ovaries or fallopian tubes are removed, the medical literature, the operative report would say additional words, with oophorectomy being removal of the ovaries and salpingectomy being the removal of the fallopian tubes. So you would have a hysterectomy plus these other components depending on what's taken out from your surgery. Additionally, description of the hysterectomy does not say anything about the lymph nodes, but lymph nodes are an important component of cervical cancer staging surgery. Most often now, this is now done with a procedure that's called sentinel lymph nodes, in which a dye is injected up into the cervix at the start of your surgery. And then we have a special camera where we can see where that dye comes out from the cervix and goes to one sentinel or first lymph node. And we can see that lymph node during the surgery and remove it. So we just try and take one lymph node to decrease side effects from lymph node removal. Us being able to see the lymph node doesn't say it's involved with cancer. It just says if they're cancer cells that are spreading out, that's where they would go first. And then that lymph node is looked at under the microscope with the pathologists. So as you can imagine, there are a lot of positives of trying to get extra margin or tissue around the cervix, but there are also risks associated with the radical hysterectomy. And these are most commonly bladder abnormalities, and that's because that extra tissue also has the nerves that feed the bladder and help tell the bladder to squeeze down and empty. So patients can have trouble with either retention of urine or incontinence or leaking of urine. There's also a risk of what's called fistulas, which are abnormal connections, such as between the bladder or the ureters, which bring the urine down to the vagina. And also there can be sexual changes associated with the radical hysterectomy. Because of these risks, one of the things that has been a real area of focus is this question, whether we could actually do simple hysterectomy, meaning go right next to the sides of the uterus and cervix, for more of our patients. Is that a sufficient cancer treatment rather than taking this extra tissue to the side? And to try and answer that question, first, there's been a lot of work looking at what are the features that would define a lower risk cancer that maybe could be treated less aggressively surgically. And there are a number of characteristics that are relevant, and we get this from the pathology from that excision procedure, either the leaf or the cone. First is the size of the tumor and how deep it is into the cervix. Second is the question whether the margins are still positive. When you had that piece of cervix excised, was there still cancer at the edges? The histology, such as squamous cell or adenocarcinoma. The grade, which is looking under the microscope, how abnormal are the cells? And this is different than the stage. It's just at the cellular level, how abnormal are they? And then a concept what's called lymphovascular space invasion. And these are channels that are going to the lymph nodes. So even if the cancer is not in the lymph nodes, do we see it in these channels as if it's trying to get into the lymph nodes? So all of these help us know what is the risk of that cancer coming back and how aggressive do we need to be. So based on these criteria, there were two important trials that have been published relatively recently, one called the SHAPE trial and one called the CONSERVE trial, looking at the ability to do a simple hysterectomy in women with low risk cancers. So this includes tumors less than 2 centimeters, those most common histologies, depth of invasion that's not too deep, and then they actually varied a little bit on the last 2 points about the margins and this lymphovascular space invasion. So we'll talk in a little more detail about the SHAPE trial. And the reason is this is a particularly robust trial because it was what we call a randomized phase 3 trial. So patients with specific criteria for their cancer were randomized to either get a simple hysterectomy or a radical hysterectomy. You can see the pictures here, again, highlighting the differences in that surgery. And then additional comments, they all had their lymph nodes removed. And then surgery could either be with a large incision, what's called a laparotomy or an open surgery, or with smaller incisions. And there are a number of words that folks use for that: laparoscopy or minimally invasive surgery or robotic surgery. So in this trial, either surgical approach was okay. And really the question was simple hysterectomy versus radical hysterectomy. So this is the result that they see. And so on the bottom, we have the years since surgery. And then on the side here, the percentage of patients who have recurrence of their cancer. So as time progresses, we see there are some patients with recurrence. The blue line is simple hysterectomy and the red radical hysterectomy. And overall, the likelihood of recurrence was about 2.5% for simple, 2.1% for radical, but by statistical analysis, there was no difference between these two groups. So the conclusion from this study was that simple hysterectomy is not worse than radical hysterectomy with respect to this likelihood of recurring in 3 years. They also found that patients who had a simple hysterectomy had a better bladder function and better quality of life outcomes. This PMID number, this is just our medical literature number, and I wanted to highlight this is similar to a non-randomized trial, that conserved trial that was shown in the table as well. So next, I'd like to talk a little bit about the question of surgical approach. So here are some schematics to help you kind of visualize the options. On the left is what's called laparoscopy, which is small incisions. Our instruments go through those small incisions and look inside of the camera. Most commonly, I would say patients have 4 or 5 incisions, and the uterus and cervix are delivered through the vagina or removed through the vagina. And then laparotomy or open surgery can be either done with a side-to-side incision or an up-and-down incision. So how do we decide? There are a number of factors. One is the size of the uterus, the question of whether it could fit out through the birth canal. Second, prior surgical history, the patient's body shape and size, surgeon expertise, and then patient preference. But a big other question is, does the presence of cancer influence what's the best surgery approach? And there was another recent trial looking at this question called the LAC trial, the laparoscopic approach to cervical cancer. And these are patients who all underwent radical hysterectomy, so the more aggressive surgery with the broader margins. And half the patients had a minimally invasive robotic surgery and half underwent open surgery, and they looked at the outcomes. So this is a similar graph in that we have time on the side or on the bottom here, and instead it's flipped the other way. So this is the number of patients who did not have recurrence of their cancer. So what we want is to be disease-free. Higher is better here. And what we see is that the group that did better is the green line, or the open surgery, while patients who underwent minimally invasive surgery had more recurrences or were less likely to be disease-free as time progressed. And overall, the results from the SLAC trial showed that patients are almost 4 times less likely to have cancer recurrence if they had open surgery. And then when they looked at overall survival, the survival rate with laparoscopic surgery was 90.6%, and open surgery had a higher survival rate at 4.5 years at 96%. All of these data suggesting that open surgery is better for cervical cancer than laparoscopic surgery. So was really a surprising result, I would say, and caused a lot of discussion of why, and the question of whether this is related to surgical technique. One hypothesis is that it's due to what's called a uterine manipulator. This is a surgical device that we use. It goes up through the cervix and into the uterus to help us move the uterus, and then we cut along this blue ring to remove the uterus and cervix. And the question of whether putting this in pushes the cancer cells out was one concern. Other possibilities are other aspects of tumor spill. If a patient did not have a cone or a leak before, if there was inaccurate staging initially, or there's also a lot of question whether larger tumors are particularly prone to worse outcomes with laparoscopic surgery. So there are a lot of unanswered questions, and given the benefits of laparoscopic surgery for patient recovery, we're really trying to figure out this question. So there are 2 trials currently asking this. The first is what's called the ROC trial. It's enrolling patients in the United States, and they're looking at robotic versus open radical hysterectomy with some specific adjustments to help improve our control of the cancer. First is we have an MRI to make sure that the cancer size is accurate. And second, uterine manipulators are not allowed, and there are other strategies for covering over the cancer on the cervix before starting the surgery. So that's about robotic versus open hysterectomy. In radical hysterectomy, we're also looking at laparoscopic versus open surgery in patients who undergo simple hysterectomy, looking specifically at that lower risk set of patients that are in the SHAPE trial. So these will be important questions as far as the best surgical approach. And then I wanted to close with just two additional comments about surgery. As I mentioned in the beginning, hysterectomy doesn't comment about the ovaries and the fallopian tubes. And there are two specific procedures that are sometimes relevant with patients who have cervical cancer. First is ovarian transposition, and then the second is a concept called opportunistic self-injectment. So ovarian transposition is a strategy to move the ovaries for women who may require radiation for their cervical cancer or actually any other pelvic radiation. And the goal is to keep the ovaries up away from the radiation to decrease the chance of them being affected in premature ovarian failure. So if we look at this picture on the right here, this is the normal location of the ovary and the fallopian tube next to the uterus, and the cervix is at the bottom. And instead, what happens surgically is that ovary is moved up outside the pelvis, kind of to the edge of the pelvis, what we call the pelvic rim, so that it's away from radiation that would be administered down here to the cervix. It's important to note that there's still some risk of ovarian failure with transposition, to 50% with radiation, and a small risk even without radiation, perhaps due to changes in the blood flow. And then finally, just a brief comment about the fallopian tubes. We now know that the majority of ovarian cancers actually come from the fallopian tubes. So there's an increasing effort to remove fallopian tubes in women who are done with childbearing. So often if a patient is having surgery for cervical cancer with their uterus and cervix removed, and they're keeping their ovaries because they're still young, we would generally take out their fallopian tubes to decrease their risk of getting a fallopian tube or ovarian cancer. And this is called the self-injectome. There's conflicting data. We still aren't sure whether the self-injectome can influence hormonal function and age of menopause in these patients. So to end, a few important take-home messages from today. First, that pathology from the initial cervical excision, as well as advanced imaging, allow us to really accurately stage a new cervical cancer and assess for risk factors. Second is that surgical clinical trials are really allowing us to define the optimal surgery for early stage cervical cancer. And our goals are the lowest short-term and long-term risks, but still controlling that cancer. And then finally, during surgical planning, every component of the surgery is carefully decided. The cervix, the tissue surrounding the upper vaginal tissue, the ovaries, the tubes, and all of these details should be discussed with your surgeon. So I'll end there, and I'm happy to take any questions.
Oh, thank you so much for this presentation. It was extremely informative. Really appreciate it. We do have some questions, so let me just get these going. So there were a few pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as we can with the remaining time. So can you explain what less aggressive surgical management means? How is this approach different from traditional surgeries?
Yeah, so what I mean by less aggressive is this question of radical versus simple hysterectomy. I mean aggressive with regard to how much tissue is removed and whether we can remove less tissue and have less side effects while still adequately controlling the cancer.
Okay. Are there specific factors that determine if somebody is eligible for a less aggressive surgery?
Yes, so these are those factors that we learned from the initial excision of the cervical tissue. So the likelihood of the cancer coming back pertains, I would say the size is really the most important. And so the SHAPE trial that I talked about included all tumors less than 2 centimeters. Stage 1 cancer is can be up to 4 centimeters, but those patients who have like a 3 or 4 centimeter cancer, still our data say radical hysterectomy is best. But the smaller tumors, less than 2 centimeters, as well as a scenario where all of the cancer that we can see was removed on the cone that was taken out, so the margins or the edges are negative, in that situation, if the edges are negative, then more likely a patient could have a simple hysterectomy.
I see. I see. Okay. Can you talk about potential side effects or risks associated with different types of cervical cancer surgeries?
Yes, so as I mentioned, radical hysterectomies tend to have more side effects, and that's because the tissue to the sides of the uterus and cervix, called the perimetrium, extends to the same area where the ureters bringing the urine are coming down. So the urine is coming down on the sides of the uterus toward the bladder. And when we take out that perimetrium, we disrupt those nerves that are going to the bladder. So that's why people can have bladder dysfunction. And most often, if that happens, it's a short-term side effect, but there is the risk of long-term bladder problems. That is the most common, like, serious side effect associated.
I see. I'm glad you mentioned that. I too had cervical cancer and it was in the perimetrium and they wouldn't do the hysterectomy and I never quite understood why. I just kind of
Yeah,
went with it.
that's a slightly different reason, actually. So,
Oh, I see.
uh, so if the cervix, if the cancer has already spread past the cervix and into the perimetrium, then it's more than a stage 1, and
Mhm.
there's no, I think of it as there being no, like, natural boundary then, like,
Same.
or partway out the perimetrium, or a lot, we can no longer make sure we're getting all the way around it.
I see.
For the situations where radiation is really the better strategy.
Mm-hmm. Good to know. Um, how can patients know if they're receiving the latest or best possible surgical care for their cervical cancer?
I think this is a really important question, so I'm glad you asked. I would say there are really two things. The first is that you should see a gynecologic oncologist and not just a general gynecologist for your care. General gynecologists will do hysterectomy for non-cancer reasons, but gynecologic oncologists have much more experience and the latest knowledge about surgeries. So the first is gynecologic oncologist. The second is amongst cancer centers. There's a subset of cancer centers that are designated nationally as being comprehensive cancer centers.
Mhm.
And these are called NCCN cancer centers. And so comprehensive cancer centers are particularly adherent to guidelines and participate in actually setting those standards to make sure it's the latest care.
Awesome. Thank you for that. Are there any advancements or research currently underway that might impact cervical cancer surgeries in the future?
So I mentioned two trials. One is looking at laparoscopic versus open, or large versus small incision surgeries for radical hysterectomy, as well as that same question really for the simple hysterectomy. So that's one component. The other thing that I think is important is there's a lot of research also about HPV vaccination and prevention as well.
Awesome. Okay, I guess there's what we can do. One more question. I guess to close it out, how can patients work with their healthcare team to decide on best treatment approach for their unique situations?
Great question. I think the first is to feel comfortable asking questions and asking why, because I think sometimes we forget what folks know and don't know. And so if something's unclear, make sure you ask. And then to remember that hysterectomy is a very broad word. And I would say of the pieces, outside hysterectomy is the question of what are you going to do about your ovaries? And that's an important conversation to have with your provider.
Thank you. Thank you so much, Dr. McLean, for your thoughtful and thorough answers to these questions. We'll have a recording of this program available on our website in 1 to 2 weeks. Please also check SHARE's website for upcoming educational programs, podcast episodes, and support groups. Don't forget to follow us on social media. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. This concludes the webinar. Thank you again so much, Dr. McLean, and I hope everybody has a great rest of their day.
Thank you.
Thank you.